I'll be talking about the role of intravascular imaging and stenting of lower extremity venous outflow disease. It's a kind of a mix of a talk and a case that I had just recently. I have no disclosures, no industry funding. So just a quick, briefly overview about iliac vein compression. It's more of a syndrome, not a disease. You know, it's been around for quite a while. First described by Dr. Virchow, who noticed iliofemoral DVT was more common in females on the left side. However, the syndrome itself was described a century later by Dr. May and Dr. Thurner that linked actual iliac vein compression with overriding arterial in 1957. But now we know that iliac vein compression exists in both sexes, male and female, both sides of the body, and all age groups are affected. Symptoms vary greatly, anywhere from iliofemoral DVT to venous ulcers and everything in between. But if you see these patients in an outpatient setting, you notice most of the time they present with just lower extremity edema, and this just sort of goes on with the workup. The disease itself is a natural progression. Autopsy studies show that a lot of people have asymptomatic compression, but genetic predisposition or just environmental factors over time, the vascular trauma from an overlying iliac artery and repetitive compression onto the vein triggers an inflammatory response into the vein, which actually causes the stenosis. And then stage 3 actually causes symptoms, which is anywhere from acute DVT to symptoms of chronic venous insufficiency. So basically, it can happen bilateral, but we do know, in contrast to the right common iliac vein, the left common iliac vein has a more horizontal course, therefore it's more commonly involved, but clinically we see it all the time bilaterally. Diagnosis of iliac compression syndrome, you can begin with duplex ultrasound, most commonly available in office. If you really have an experienced sonographer, who can do a good pelvic ultrasound, you can actually detect this syndrome with just simple duplex ultrasound in the office. But those take really an experienced sonographer to do that with a lot of training. CT or MR venography is also readily available. The advantage is that's non-invasive and you're able to detect any extrinsic sources of compression, venography, and obviously the gold standard, which is venography and adjunctive IVUS. So as interventionalists, we rely on our dye, right? We love coronaries and the periphery. The dye don't lie. We see it all the time. Doesn't quite translate into the venous system. If you look at a retrospective case studies done by Dr. Raju, he looked at 304 left common iliac vein stenosis cases before and after stenting, and he actually, if you compare with IVUS, single plane venography had only a 45% sensitivity for detecting a stenosis greater than 70%. So obviously not that very sensitive. And with single planar venography, you can do multiple orthogonal views, but you will miss the lesion if you just rely on venography, especially if the lesions are diffuse and eccentric. The venography can look deceptively normal. I don't know who has the time for this, for doing a simultaneous aortography and a iliac and a venography, but here, if you see a lesion as obvious as this, you can go ahead and treat it, especially if the patient's symptomatic. But most of the time, we're not seeing cases this obvious. So why is IVUS the gold standard? Most venous outflow disease is detectable in IVUS, both thrombotic and non-thrombotic. It provides accurate area measurements for detecting percent stenosis, and especially in stent selection and treatment. Location of the iliocaval confluence, which is commonly missed in over 25% of cases when relying on plain old venography, and that's also important when deploying your stent. There's no dye. It can be repeatedly used throughout the procedure with irradiation. It's very accurate. You get a full 360-degree view of inside the vessel, rather than just relying on a 2D image like venography. You can sort of detect the etiology of the venous outflow disease. Is it thrombotic? Is it non-thrombotic? Is it from compression? Is it from fibrosis? It's all sort of discernible from IVUS. Able to locate tributaries and identify intraluminal structures such as thrombi, for example. And in treatment, IVUS is also irreplaceable and crucial. Again, finding the degree and extent of stenosis, the diameter and length of the stent that's needed or balloon that's needed, exact placement of your stent, proximal and distal disease-free endpoints, what we called disease-free areas of the vessel. That's vital for patency. And even after stenting, IVUS is important to assess the expansion apposition with the stent, certainly, which is important because you don't want to undersize your stent, which can lead to in-stent restenosis. So here's a case that I did recently. It's a 69-year-old man with long-standing advanced C4 bilateral chronic venous insufficiency. I sort of adopted this patient. He has history of remote bilateral superficial venous ablations in his GSV and his perforators. He's also had history of bilateral DVTs, got anticoagulated. He has ultrasound evidence of deep venous reflux as well. Despite months of compression stockings, treatment of his bilateral GSVs and anticoagulation, he was still highly symptomatic. And I was very clinically suspicious of central venous compression, thrombotic or non-thrombotic, given his history of DVTs. So I had an option here, to do the duplex, do the CT-MR, or go on to straight venography. I decided in this particular case to go directly to venography because I was so highly suspicious of outflow disease. So I did bring him to straight venography, and I don't know if couldn't get it with subtraction, but here's a run of his outflow, iliac vein outflow. Here is pretty obvious enough. He has, in his bilateral external iliac veins, you can see obvious stenosis bilaterally. Even in his common iliac veins, you can kind of sort of see that pancaking appearance of the common iliac vein. And here it's bilateral, so it's not just unilateral. So we decided to do an IVUS here, run. Here's an IVUS of his left side to see the size of the iliac veins. Is it thrombotic? Is it non-thrombotic? What's the etiology here? And if we were going ahead and treat. So here's a pullback. I don't have a pullback from the IVC, but here right off the bat, coming down on the left side, and even his common iliac vein, you see compression right off the bat. As we pull back, and this may be from years of fibrosis, but here I become more distally down into his external iliac vein. You kind of see this now, this artery or structure coming over, which is the artery actually overriding the vein, and here you see direct evidence of compression right onto the iliac vein, and this is kind of an external iliac vein. So here we clearly made the diagnosis of May-Thurner's. This is bilaterally, both on his right side as well. At this point, given his symptomatic nature and his advanced venous disease, I decided to treat. Before we did that, we got some measurements here. It's very important. You have to measure your reference size, and here we did a reference diameter of about 16, here you can see the area reduction of 88.5%, which is obviously very severe. You want to get the area in a healthy segment. You want to size your stent. You want to at least be 1-to-1 in your stent sizing, or if not a little bit bigger. Again, if you want to prevent restenosis, and more importantly, if you choose the wrong stent size, your patient will remain symptomatic. So that's absolutely essential. So here we went along and treated this particular patient. We recently got on our shelf the first dedicated iliac vein stent that was recently approved by the FDA, which is the barred Venovo stent. We treated both sides. We used a Venovo 18x100 and 18x60 on the right side, mainly because we just didn't have the long stent size on our shelf. It is available longer. We did an overlapping fashion, and on his left side, which was slightly bigger, we had to use a wall stent on his left common iliac side because the vein size were bigger, which again, it came down to what we had at the moment, and overlapped it with a barred 18x60. Here's the final, we treated it in a kissing stent fashion, and here's the final result. Patient went on to do really well. I saw him in follow-up. His edema significantly improved. More importantly, he symptomatically improved. And now he's just going to go for cosmetic work and just treat the rest of his perforator veins and whatnot. He's very happy. This is a run post. Again, it's not a long run, but post IVUS, pull back, you can see good stent expansion, apposition, and good luminal gain. So just a word about venous stents. The wall stents have been around forever, just as much as the disease has been around. However, wall stents, as we know, had no FDA approval for venous stenting until March 2019, where Bard got the FDA approval via the vernacular trial, and it was the first dedicated venous stent available in the market. Used it, worked fabulous. It answered a lot of the many shortcomings of wall stents, especially foreshortening, which we know the wall stents do, difficulty in deployment, and especially the need for extending so deep into the IVC, to avoid the foreshortening that you get when you post-dilate it. And once again, Bar Venovo has promising 1-year data, good first-year data, randomized data, and restenosis and target vessel revascularization. So conclusion, again, venous outflow disease, don't underestimate it in your vein patients. Even after you treat their superficial venous disease, look for it, especially if they're still symptomatic. You start with non-invasive imaging. However, if you have high clinical suspicion, suggest venography and IVUS. Absolutely essential to perform IVUS for the reasons mentioned before, and use dedicated venous stents. And Bard was the first one on the market. Thank you.